And welcome to the special webinar. I'm Dr. Lee Shelton from the Institute for Dental Specialists. This webinar is sponsored by BioHorizons, and we're happy to have BioHorizons sponsoring our organization this year. We have problems. Those of us who are on this line right now understand that there are problems, and they may not be problems at all. The problems that are involved with corporate dentistry, and particularly the corporate dental model, and how that may be affecting our practices and what we can do about that. Our guest today actually has worked with a corporate model. Our guest today is Dr. Andrew Ferrier. Dr. Ferrier trained at UCLA. He did his residency at UCSF, and he worked at ClearChoice for 3 years. And at that time, over that period of time, he did 1,500 arches. Well, now he's gone into private practice. He's been in private practice and can give us a full perspective as to where the corporate model is and how we might be able to take advantage of that corporate model in order to be able to help our practices. Andrew, welcome to this webinar.
Great. Thanks, Dr. Sheldon. I really appreciate the invite here. Thank you, BioHorizons, also for the support. We're going to be talking today about the corporate implant model and sort of what advantages they have in private practice versus the referral model that we have. So we're going to go into that in some depth here. I'm going to start up the presentation here as we go forward. All right, Dr. Sheldon, can you see my screen there?
Very well. Thank you, Andrew.
Excellent. Okay, so here we go. So we're going to talk a little bit about how you implement the practices of a ClearChoice type model in the referral model that we have in private practice. And this segment that we're going to talk about comes from the Full Arch Immediate Load live surgery course that I teach with Dr. Arshia Sharafi. This little segment is just a really kind of condensed, boiled down version of what we talk a little bit about when we talk business and when we talk case acceptance. And we're just going to go a tad into those two things today and also sort of explain what's happening in corporate dentistry. So we have clinical lectures that we give, which sort of talk about implant dentistry for full arch immediate load from A to Z. And then we also go through live surgery and conversions on that same day. And then we finish up doing some hands-on and then business training on the second day. So what we're really trying to promote is an A to Z approach, trying to give people who have experience some pearls, some added tips and tricks. And then for people who've never been through a full arch immediate load case, giving them the tools and the knowledge to be competent and to be able to deliver what they need to do for our patients. And business topics include case acceptance and profitability, probably the two most important things when it comes to doing full arch immediate load. So once again, that's just a little bit of a blurb about what we do and how we teach these courses. And this is just a little segment of that curriculum. So it's important to realize that not all patients are going to be full arch candidates. It's really easy to talk about this topic and talk about implants and then sort of forget about the fact that there are different treatment modalities in which we can treat our patients. You know, if we have a patient who's partially edentulous like these two kids are, these are my kids. This is Colin, and in this picture, he's about 6, and this is Charlotte, my daughter. She's about 3. You know, these types of patients, we're not going to go in there and take out all their teeth and put in implants. You know, that's kind of the bum rap that a ClearChoice model gets. Everybody comes in with teeth, they leave without, and then they've got implants and go on their merry way. But the reason I show these guys is because they tell a story. You know, Colin, when he was born, was a real mess. You know, he was hard to deal with. He had colic. He was somebody who, by the time he was 10 months, he was running around. When he was 12 months, he was talking. You know, you take him to a park and he's going and touching rabid dogs, chasing after fire engines. You know, he was somebody that was just a handful. And my wife and I at the time thought, okay, well, if we're going to have another kid, we better make sure we have a different kid. Otherwise, we're going to kind of die with 2 little Collins running around. So Charlotte was the alternative. She was a perfect angel. You know, she would sit on a blanket and coo, and everybody would come by and say how lovely she was. And that was a breath of fresh air for us. Also because, once again, if we had another child who was difficult, it probably would have been an end to our marriage right there. But, you know, as a young parent, I thought, okay, well, these two kids are going to be this way for the rest of their life, and Colin's going to be a little hellion and Charlotte will be my angel. But what happened is when Colin turned 10, he all of a sudden was reading, at long stretches at a time and doing artwork. And he could focus and sort of have attention in ways he couldn't before. And then Charlotte, now that she's 6 years old, she's a total diva. I get her ready for school in the morning. I can't get her socks to match her dress, and the whole thing falls apart. We're 15 minutes late and everybody's screaming at each other. And the reason I bring that up is because this is what's happening in dental offices all around the country. We have a lot of patients who may have been very stable in their dental condition for a number of years, and now maybe they had radiation treatment or cancer and they had chemotherapy, and in a very short period of time, they go from a stable dentition to a state where they're no longer, they have a terminal dentition and they no longer have options that other patients might have conventionally. And these are the types of patients we're seeing more and more of, and these are the types of patients we have to be prepared to take care of in private practice. So there are many patients who are full mouth immediate load restoration type candidates. We have an example here. This patient isn't homeless. He's not a meth addict or anything like that. His chief complaint actually when he came in was that he had one brown spot on his lower front teeth. And at the time I thought, well, you probably have a few more brown spots that we have to take care of. But he kind of knew he had a pretty poor situation on his hands. And in his case, obviously we have two different options. We have an immediate denture, or we have some type of immediate load implant restoration. And this is the majority of the patients that we're going to be seeing in private practice who can benefit from this treatment. Patients who have lots of good teeth, who have a periodontium that's stable, this is not going to be an appropriate treatment for those types of patients. And as private practice specialists, we have the opportunity to treat those patients in the appropriate manner and not necessarily using full arch immediate load. But full arch immediate load does have its place on the spectrum. And like I said, when a patient like this, who's going to become a terminal dentition, presents, that's what we're going to think of, and that's what we're going to use when we have to treat a patient like that. So here's an example. We've taken this patient from a state of degeneration, and we've given him something back in his mouth that's going to be stable and predictable over time. You can see that we can establish any type of occlusal scheme that we want. You can appreciate that there is a level platform where our prosthesis hits the gingiva, and that's going to give us good cleansability over time. And so delivered in the right way, a full arch hybrid prosthesis can be very cleansable, functional, long-lasting, and that's what we're really looking to achieve with this type of treatment. And with most of these patients, what we're really looking to do is transform them. If you look at this patient on the left here, he has really an apprehensive look in his eyes. He doesn't want to be photographed. And you can see once we've completed our treatment, all of a sudden he's got some life back. He's really smiling, he's happy, some years have been shaved off his life. And this is what we're trying to do with our patients. And it's really important when you're in the consult room, we're going to talk a lot about case acceptance, about when you're in the consult room that you convey this type of transformation to your patients. And you have to be able to see it and believe it that this is going to happen. So it's very important that every person along the way in your referral network, especially if you have a general dentist who might not have done many of these before, they have to understand that this transformation occurs, and that it's a very important selling point for the patients that you're going to talk to. So once again, we go from a state of a terminal dentition to a state of rehabilitation where the patient's going to be happy and stable. Here's an example of a radiograph from 10 years ago. This patient, after 10 years after treatment was delivered, you can see that he has very stable bone levels, and a lot of this can be attributed to the angled implants and giving a good AP spread and not having excessive cantilevers, which is really important when we deliver this type of treatment. But he's been very stable over 10 years. This is the type of result that we see over and over in our patients. It's a very successful treatment modality, and it rivals those cases where you have implants placed and then a full reconstruction done secondarily after using a denture. So whether you load or whether you don't load these types of implants, the success rate of the implants is going to be the same. So what we're going to talk about right now is why full arch is such a big deal right now. We're going to talk about how to get referrals to recognize patients and how to increase your referrals case acceptance. These are really the things that we want to go over so that we get a good sense of, from the front end, how you're going to move people in and out of treatment. Then we're going to talk a little bit about our live surgery course to end. So why is full arch immediate load such a big deal right now? It's all based on demographics. So it's relevant in all dental practices because of the aging population. And we all know that this is becoming a huge deal. That's why healthcare in America had a crisis. And whether you like Obamacare or not, it's a response to try and deal with the problem that we're having with so many people entering the age of over 65, which is where we're going to be in terms of Medicare and having to deliver more care to an elderly population. So if we look at the population 65 years and older, in 2005 in North America, there were 40 million people who were in that category. By 2025, that number doubles. So we're starting to see more and more patients who are getting older and are living longer, but have more dental and medical needs. And if you think about that growth, that's over a 20-year span. We have 100% growth there. That's a tremendous number of people. And most patients who need some type of full arch immediate load are over the age of 65. So we're really entering into a time when we're seeing lots of patients, and that number is not going to go down for some time. So we're going to see that continue to spike, and this is why this type of treatment is becoming more and more accepted and a desirable treatment for these types of patients. So we have an increasing number of older people. People are keeping their teeth longer, which is good for dentistry. That means we have more dental visits. The prospective decline in edentialism is actually being overrun by the offset of 80% increase in the adult population. So we still have somewhere around 30 to 34 million fully edentulous patients in the United States. Once again, that's a huge population for us to be addressing their dental needs in terms of implants. People reaching the age of 65 are living an additional 17 years. So we're seeing patients who are very systemically healthy, but they're basically living longer than their teeth, and so they have to have something done. And 20% of all US adult Americans wear some type of removable denture. That's a very, very high population of patients who need dental implants. And so it's something that obviously is becoming a big deal. And corporate dentistry understands this. Corporate implant centers have been sort of popping up all over the place as time has gone on. ClearChoice has been around since about 2005. And these types of centers are coming around because they understand that there's a high level of profit with these types of services. And so we know that if, from the introduction of these centers, that this is an area that we should also be focusing on as well in private practice. ClearChoice Implant Center is probably one of the most prominent. Chrysalis Dental Center, Real Choice Dental Center, Western Dental, Aspen Dental, Pacific Dental Services, all of these different corporations are providing services for patients, and most of them are doing it on a basis where they haven't actually trained the professionals who are doing this type of treatment. So a lot of these dentists haven't actually been trained to do full mouth reconstructions or full arch immediate load, and then they're being asked to perform those services. So there's an issue with accountability in a lot of these corporate implant centers. ClearChoice Implant Center, like I said, began somewhere around 2004, 2005. They started in one location in Denver, Colorado. And by 2009, they had about 9 centers that they had established. My office was the 9th center, and my office was a satellite center. And the satellite center was a center where you had just a prosthodontist, and we would see patients for consults, and we would recommend treatment. And then when the patient signed up for treatment, we would send them down to a surgical center. And the surgical center was typically, anywhere from 20 to 50 miles away from where the satellite center was. And the satellite center was established because they realized after setting up a center in Chicago that due to its position downtown and the fact that there's so much traffic around, they were actually losing a lot of money at that center. And so they realized they needed to have ways to take people from the surrounding areas and to bring them into the surgical center. That's the way the ClearChoice model works, is heavy on TV advertising. And so when you market, you're actually going to be marketing to a very large DMA. So your market area could be, say, 60 by 70 miles, something like that. And because of that, that means you're going to be hitting a lot of people, but your center, even if it's centrally located, might not be accessible. And so my office was the first office where we developed this satellite center, the idea of taking a patient and moving them from one office to a surgical office and then right back for treatment, which, when we think about it, is identical to the referral model that we have in private practice. A general dentist will see a patient, they'll send that patient to a surgical specialist, then the surgical specialist will do whatever treatment they're going to do and send them back to the restorative dentist to finish off the treatment. So there's really no difference there. And originally, ClearChoice thought their big selling point was that they built very, very large offices, very large surgical offices, 10,000 square foot offices. And there was this big wow factor that the patient would see it and then would have to sign up. But in reality, it's not about the wow factor. It's about how you show a patient that there's synergy in between all of the centers that you're using. And the real key is gaining trust of the patient at the time of the consultation. So it's not like you have to be all in the same space like ClearChoice touts. You just have to make sure that the patient feels a connection between all of the parties involved in their treatment. And so when we talk about doing consultations and we talk about how you refer patients back and forth, it's very important to realize there just has to be a lot of continuity and synergy between the parties involved. So if we look at ClearChoice here, this was back in 2009 when I joined ClearChoice, and there were 10 centers. If we look at what happens by the time I left ClearChoice, which was 2012, at that point in time, there were about 23 centers. And you can see there are a number of clusters of centers that have occurred here. And that's because the satellite model was very profitable. My office during my time at ClearChoice was the most profitable office of any of the centers. And that's because my overhead was low and we did great getting good case acceptance and driving patients through. So once again, it's all based on gaining trust from the patients and doing it in a very efficient manner, which leads to great profitability. So now ClearChoice, if we look at the model, has multiple centers in very large metropolitan areas. So they've gone from using the center model in some of the cities like St. Louis and maybe Las Vegas, and now they're moving it into the cities like Los Angeles, Philadelphia, New York. These are the areas where ClearChoice is expanding to. So ClearChoice has a very solid business model that they've been using, and it's very predictable, and they're moving all across the country. So we know that what they do works, and that's why what they are doing in the consult room is something that we want to duplicate in order to be very successful with our patients as well. So ClearChoice has a team. They always say that they have a team of a prosthodontist, an oral surgeon, and a laboratory all in one place. This is important for them because they can talk to patients about having everything under one roof. That's one of their big selling points. They have a lot of marketing. ClearChoice spends about $100,000 to $200,000 per month in each market where they're operating. So obviously, their market spend is going to be higher than most dentists in those areas. They have a lot of money. Venture capital has come in and bought ClearChoice twice. So they have a lot of money to work with in terms of R&D and then being able to spend on different areas that they need to in order to grow. The real key for them is they have a concise sales process. So when I joined ClearChoice, there was a training program that took place for about 2 weeks in the corporate headquarters. And what they did is spend a week on how you actually sell patients in the consult room. And we can use the word sell, or we can talk to them. We can talk to the idea of, convincing patients. But either way, it's an idea that we're trying to persuade patients to do what's right for them. So they called it a sales process. They have a proven business model, which has worked all over the country. It worked during the housing crisis when homes in the city of Cleveland were valued at about $20,000. They continued to sell arches in Cleveland for $23,000. So that really shows us that what they've done has worked over time, even during stressful environments. And now they do what they call the general dentist referral model. And this is a very interesting approach that ClearChoice has. They've started to go out into the community, and they are starting to solicit dentists for patients. So they're actually going out and trying to get referrals from what would normally be our referral networks. And typically they'll compensate a dentist $2,000 to $2,500 per patient for them to refer that patient. The dentist is required to attend the surgery, which is how they sort of get around any sort of fee splitting or paying for a patient as a referral. And to me, this has a little bit of a questionable legal standing. So if any of your referrals are actually doing this, you might just want to bring up the fact that this, in most states, still doesn't pass muster if you are doing this with ClearChoice. But this is actually a threat more than the overall external marketing that ClearChoice is doing. ClearChoice's external marketing is good for everybody who's in that area, because when patients see the advertisements, they are curious about what type of immediate load treatment can be done. And so they start to go, especially if you're a dentist and they're your patient, they'll come to you and ask about this type of treatment. Oftentimes they won't go to a ClearChoice center first. So because of that, if you're prepared and ready, you can oftentimes get patients to sign up with you as opposed to a corporate implant center, because you're prepared for that and you have a method in terms of getting that patient to move forward with treatment. And that's part of what we talk about at our live surgery course, is we really want to be able to show how you can actually be prepared and what type of implementation you need to have to get the patient moving forward. And as a surgical specialist, it's very important that if ClearChoice is getting out into the community and seeing your referrals, then it's important that you as a surgical specialist have a plan and make it easy for a referral to refer you cases if they've never done it before. So that's a vital part of this, is to be prepared. And when ClearChoice comes to your area, or if people are heavily competing in a certain market, you need to make sure that you are setting yourself apart by really helping your referrals and making sure that they feel comfortable when it comes to these cases. And that really boils down to giving them good education, which is another thing that we do at our live surgery course, is how you do that. So in order to compete with corporate implant centers, we need to provide equivalent services provided by those companies. And as long as you're trained properly, obviously, to do a full arch at ClearChoice and to do a full arch in your private practice is really no different, so long as your clinical skills are up to snuff. The real key is you want to differentiate yourself with a better experience. So ClearChoice has a lot of patients moving through. Typically in a ClearChoice office, we would do anywhere from 30 to 50 arches a month. And that means you're not able to spend quite as much quality time with your patients. And so one of the things that we really need to focus on is having that better experience, because that's what's going to lead patients word of mouth to having more referrals to you, which is still, even though there's a lot of external marketing out there, internal marketing and word of mouth referrals from patients are always the least expensive and the best types of referrals to get. So we want to make sure that we are accountable, unlike some of these other corporations. Even ClearChoice at this point in time is having problems because they can't hire surgical specialists who are going to be affordable. So they have to hire residents right out of school who don't really necessarily have the amount of experience that we would want to have if they're treating these patients. So the accountability is a little bit lower than we would want. And one of the other things we can always provide our patients is maintenance long-term for their overall health. And this is something that ClearChoice centers can't provide because the clinicians come in and out of there very quickly. So one of the things we always want to do, like I said earlier, is take advantage of their marketing. They're spending $100,000 to $200,000. And what happens, like I said, is people will see those ads. They'll go to ClearChoice. They'll have an experience there that might not be a very acceptable, palatable one for them. Oftentimes, ClearChoice can seem a little bit like they don't care as much. and they're sort of like a big box Walmart type of feel. And those patients who don't want that will respond and decide to see another practitioner. So you need to be prepared for that consultation after somebody's been to ClearChoice. So typically referrals often say that the patients that we're looking for full arch immediate load aren't in their practices. And oftentimes I ask them, are you so sure? You know, if we look at a patient like this, here's an example of a patient whose chief complaint is that number 10 has lost a crown. And we can also see that there's caries on number 11 on the distal. And so this type of patient has different treatment options. You know, the patient has some teeth remaining. The FPD going from 6 to 8 here is a little bit precarious. But there is an option of maintenance. You could put a new crown on 10, do a crown on 11, and then we could be thinking about another RPD. So that's another option for this patient. However, a patient like this, if they don't want to deal with teeth that are failing, if they don't want to continually go down the cycle of losing a tooth here and there, might decide for a more permanent option. So these are the types of cases that oftentimes referral dentists may not see or may not recognize because they see teeth and they think, okay, this patient has teeth. They're not really a candidate for implants, and that's not something that they're going to look at. So it's really important that you train your referrals how to see these types of cases. Here's another example, a patient who's been through perio maintenance for 20 years. Number 11 has caries, and so she needs to make some sort of change. So she could, once again, another removable partial denture. She could then have more perio maintenance, but in her mind, she's at this point done with having her teeth. And even though we have healthy roots and a healthy periodontium on a number of these teeth, there's still the issue of having to maintain these teeth over time and having to continually worry about wearing a removable device. And if we look at the bone that this patient has, she's blessed with a lot of solid bone. So there's no question that she's a good candidate for full arch immediate load. And so one of these types of patients, once again, may not be recognized from your referral base. Here's an example of a patient. Patient's been through 2 full mouth reconstructions up to this point. She saw a prosthodontist in my area, and the prosthodontist recommended doing bilateral sinus lifts and grafts, posterior implants in both the maxilla and the mandible, full mouth reconstruction. And she'd been through 2 full mouth reconstructions before, had lost posterior support, had caries on all of the remaining teeth. And so in a case like this, perhaps it's not the best treatment plan if we're deciding to keep teeth if she continues to have recurrent decay. So an example like this, where a patient once again has teeth, but we're deciding that in this case, it might be more predictable for us to do implants. So in this manner, we're trying to give different options for patients, but if a patient has a more predictable solution with full arch immediate load, then that's the type of treatment we might employ. Here's another example. This is the patient. This is the grandfather of a patient who is in my practice. He came in and hadn't seen the dentist in about 30 years, but she had a friend in the practice who had a full arch done. So she knew that that type of treatment was available. He was referred in, and you're going to have a lot of these patients these days coming in like this as referrals from relatives and friends. And then he decided he would do a full arch in the maxilla. And obviously in the mandible, we also have some periodontal disease and other issues. In this case, he did the maxilla, and then eventually he came back and we did the mandible at a later date. And that happens often. So once again, it's not that we're going to take out solid, good teeth all the time, but we're looking for implants as a more predictable solution. And a lot of these patients do not want to go through immediate dentures. They don't want to have 8 implants placed and do traditional crown and bridge on implants. They often want to do immediate load because it's going to give them teeth right away, and they're not going to have to go through that treatment and the added expense that's associated with traditional crown and bridge. So what makes a good full arch candidate? Severe caries is probably the most prevalent these days. A patient who has gone through radiation therapy or chemotherapy, those types of patients have a dentition that's rapidly falling apart. And those are the ones who are going to be, once again, good candidates for this type of approach. Severe periodontal disease is pretty common as well. Patients over the age of 70 are likely to have periodontal disease. I think it's like 80% of those types of patients are going to have periodontal disease. And they're often going to need a transition from their natural dentition into something different. Completely edentulous patients are obvious. Partially edentulous patient with compromised abutments. These are the #1 types of patients that we're seeing in my neck of the woods, which is over in San Francisco area. So in different areas of the country, you might see more edentulous patients. You may see partially edentulous patients, but it just depends on your demographic. Almost always, these types of patients who are partially edentulous are going to be very prone to moving forward. And we're going to talk a little bit about that when we talk about the consult room. So if we look at a patient like this, there's no question that this patient has some serious issues in terms of their dental health. This patient hasn't seen a dentist for 45 years. He is 45. He has also, if you looked at this, created calculus bridges between all of his teeth, and now he's bruxed through the calculus down on the lower arch. That's pretty impressive, and that's it's amazing stuff there. So obviously this patient, these teeth are prone to be lost. And so once again, the treatment options would be an immediate denture, or we could do something like full arch immediate load. So those two options are available to us. If we look at a patient like this, the question is, what type of treatment are we going to do for this patient? You know, this patient has to lose all of the posterior teeth due to periodontal disease and caries. You know, the remaining dentition has recurrent decay on every tooth, and I think there are going to be 6 root canal therapies that were going to be necessary. Crown and bridge was going to be needed for the remaining dentition. So her treatment plan overall was going to be a full mouth reconstruction mixed on natural teeth and on implants. The treatment time frame would be extensive, and the patient didn't want to go forward with treatment. So in this case, we have teeth that are much more stable and are much more healthy. But the question is, do we want to do treatment that the patient is not wanting to pursue, or do we give a patient treatment like a full arch immediate load? Now, everybody's going to have a tipping scale on this. Some people are going to be more aggressive and some people will be less aggressive. And that's totally fine. We're all going to have our own definition for that. But there are these cases that are going to be a little bit tricky. And as long as you inform the patient of all their options and give them all of the alternatives that exist for that patient moving forward, then I think whatever patient, whatever option the patient pursues is going to be the best option for that patient. So in this case, we did upper and lower full arch immediate load restorations. And this patient at the time that she got her therapy done was about 67. If this patient had been 24, this would probably be a different decision that we might have made. Okay, so we find a patient, we recognize that patient, everybody gets excited, the tie flies off, and now the question is, what do we do? So in terms of our appointment sequence, you know, we're going to have a restorative consultation. That's the first point of contact for our patient. And that's a very important visit, because if you can't get a patient moving forward with treatment, it doesn't really matter how good you are clinically. After that, we're going to have the surgical consultation and a treatment acceptance visit. Now, this model is assuming that you have a general dentist who has the patient and that they were going to refer to the surgical specialist for a second consultation. And that's typically what we're going to see in most areas in the U.S. In my office, I do all of the restorative consultation and the treatment acceptance myself. And then I have a periodontist who comes into my office and places implants for me. So in my neck of the woods, that's a little bit different. But in general, like I said, a restorative consultation will occur, and then that will trigger a surgical consultation as a follow-up. Then we're going to obviously have our diagnostic workup, prosthetic planning appointment. We're going to do surgery and immediate denture conversion. We're going to have follow-up appointments and restorative appointments, delivery of the final prosthesis, and hygiene. So what we're really looking at here is just talking about this first step of the consultation. In our live surgery course, we go through each step in detail so that we can once again go from start to finish with good workflow, and then also very efficient treatment, so that we can make sure we're profitable and that we're saving time and energy in the chair. So the keys to case acceptance are understanding the patient. A lot of times we don't put ourselves in our patient's shoes, and we don't actually take the time to understand what they're going through. Establishing trust is the most critical part of this scenario. And you need to make sure patients understand their dental situations. A lot of patients will come in and they'll say something like, oh, I have some teeth that are hurting me, but they don't own the fact that all of their teeth need to be extracted and that their dental condition is terminal. So it's really important that they understand that, because if they don't really feel like they have a large enough problem, then why would they ever take out their teeth and do implants? So it's important to really frame it correctly so that they know what they're up against and what they should be anticipating. Every time you do a consultation, you always have to have a call to action. So if, for instance, we do our consultation, the restorative dentist does the consultation, at the end of that consultation, the restorative dentist needs to take the patient up to the front desk and say, okay, we've done our consultation, now let's set you up for a free consultation with Dr. Jones, the periodontist. So that's always got to be what you do. You never let a patient go home and think about what treatment they're going to need. You have to make sure that they're going to move forward and at least take the next step to moving towards treatment. Okay, so when we think about what patients are going to be dealing with when they come into the chair and the consultation, you know, there are three different patient types that we're going to see. So we have a fully edentulous patient, a partially edentulous patient, and then the fully dentate patient. So these three categories are what we're going to have to think about in terms of their emotional motivation. Really what has to happen is when you do a consultation, you don't just inform patients. You really have to get them excited and get them motivated because of their emotional response to things. So most of the time, it's not enough just to say implants are going to be great and take care of your life. You really have to have the patient express how they're feeling, and then you apply some of the principles we're going to talk about and make that patient feel how it's going to change their life. They have to really understand that before they move forward. If you think about when you go to a car dealership and you're going to buy a car, the car dealer will always bring you into the car and have you test drive, because you're going to get an emotional response in terms of how it feels to drive the car. That's always the technique that they're going to use. And like we said earlier, you're going to have to elicit that emotion from the patient in order to make them want to buy their new teeth. It's really important that you get this emotional motivation moving forward. So for an edentulous patient, they have fear that their teeth are falling out. And that's something that they've dealt with over time. This is kind of, I always talk about the picture or the YouTube video where there's the old grandmother and she's skydiving and she has the set of dentures that come flying out of her mouth. And she's still, you know, happy and smiling and her gums are flapping around. But that's kind of the vision that most of these patients are going to have. They've probably been dealing with this for a number of years. So most of the time the patients have been getting by, and in their mind, their situation isn't terrible. Nobody wants to feel that they're in a terrible situation. So oftentimes they're kind of dealing with things. And if a patient has a fairly well-fitting denture, they might not even be pursuing implants. So it's these patients who have pretty poor-fitting dentures over a long period of time where you have to basically show them that there's a better option and that getting by is no longer a good enough option. So that's really the key for these patients, is to get them over the hump and show them that there's a better way and express to them that the value of the treatment that they're going to get far outweighs the cost. That's one of the real crucial things that we're going to talk about in terms of how you deliver your case acceptance. And once again, patients need to be convinced that getting by is no longer good enough. So for partially edentulous patients, they have the fear that they will have dentures, and that's the fear of the unknown. So that's the most powerful fear in the human condition. And so these patients are primed to want to do something other than just lose their teeth, other than go into immediate dentures. So the vast majority of these patients really want to end the cycle of tooth loss that's occurred over years and years. And so they're at this point getting to the time where they don't want to do other treatment that's piecemeal. They want to make sure that they have a definitive solution. And when a patient comes to that point, then full arch immediate load makes a lot of sense to them. And so these are the cases that sometimes we're going to have good teeth and that they may need to be sacrificed to have a better, more predictable implant solution over the long term. So these patients don't want to continue the cycle, and they're very prone to moving forward with treatment so long as you tell them about how the cycle can end and you express to them that they can have a definitive solution. A fully dentate patient oftentimes does not know they have severe dental diseases or issues. Oftentimes they have periodontal disease, and most of the time it's not painful. So these types of patients, it's very important to take time for them in the consult room. So most of the time I might do 2 or 3 consultations with a fully dentate patient because their treatment is going to be very different than a patient who's already had a partial denture. Any patient who has never worn some type of removable prosthesis, if you remove all of their teeth and then give them some type of provisional prosthesis, it's going to feel extremely foreign to them, and it's going to be very uncomfortable, and they're going to be very unhappy unless they've been informed very well. So it's important to take extra time with these patients to make sure that they understand where they're going to be. And emotionally, they have to be in the mindset that they need to have this treatment. A lot of these patients still won't really have come to a sense in their mind that they need this type of treatment. And before you do full arch immediate load with a patient like this, they have to have that in their mind. Otherwise they're going to be unsatisfied. So we talked about the patient category. The other thing we have to think about when we're in the consultation room is the DISC personality assessment. So this personality assessment looks at every individual and categorizes them into 4 different categories. There's a dominant category, influential, steady, and conscientious. And each one of these has different characteristics that are associated with them. If we look at this character, Warren Buffett, he's obviously a dominant type. He's direct, he's bottom line, he is a leader. These are the types of patients who are going to be about 5% of the population, and they're going to be CEOs, business leaders, that type of thing. They're going to want treatment efficiently. They're going to be wanting to make sure that they don't have extra time that they have to expend in order to get their treatment done. And so this is the type of patient who, when they come in, is going to be speaking very quickly in short tones. They're going to make sure that they establish their dominance, and you have to respond in kind. So it's very important that you understand when they're coming in there that you also have to respond in the language that they're speaking. So if they're speaking directly, you also need to speak directly to speak their language. There's an influential type. This type of patient is excited and emotional. They're very team-oriented. And this type of patient, when you're doing a consultation, you actually want to say the word team over and over again. You want to say, you're on my team. We have a great team. My team in the office is fantastic. You keep saying that word team because this influential type really wants to be a part of that. This is the type of patient also that you want to have on your website when you have video testimonials. This patient is going to talk to 1 million other patients about how they had a wonderful experience because they are very social. This is about 15% of the population. The steady type of patient is about 60% of the population. And this patient is calm and family-centric. Most of the time, this might be a married woman, and she probably has kids that she's already put through school, and now it's her time to get her teeth taken care of. That's a very, very common presentation. And it's very important that you deal with this patient in a softer way than you would the direct patient. This patient is not going to be the decision maker in their household. So if you want the patient to move forward with treatment, oftentimes you have to have the decision maker come into a consultation. So you might have to do 2 consultations for this steady person. And that's important to realize so that you don't let the patient go. If you just say, hey, why don't you go home and think about this? The patient goes home and their significant other probably tells them, well, this is going to be too much money. I don't think we should do this, because they haven't heard the consultation you gave. They don't understand what the patient will get back. So for this type of patient, having that other person come in right away for a second consultation is very important, and that will drive better case acceptance. So the conscientious type is about 15% of the population. This type of patient is process-oriented and systematic. So we're looking at like engineers and CPAs. These are the only patients you actually need to talk science to in the consultation room. In the consultation room, our goal is to get the patient understanding what type of treatment is going to be available to them and to move them forward in terms of signing up for that treatment. But we don't necessarily talk about science or anything that's oriented around osseointegration or things that are technical. The reason that is because the other three categories, they will start to zone out and don't really want to hear about those types of things. This conscientious patient is the only one who wants to talk about the details. And so this patient is the one you have to talk about the details, you have to talk about the science, and this is the one that's important with. So communication obviously is the key to a consultation. When we do this consultation, the real key is asking questions that are open-ended. So an open-ended question is something like, do you feel like your pain is getting in the way of your life? So that the patient has to respond, as opposed to, are you in pain right now? And the patient says yes. So we want to make sure that we're asking open-ended questions. When we ask open-ended questions, that means patients have to respond. And when they respond, they start to talk and they start to elicit their own emotional responses. So it's very crucial that when you're doing your consultation, you ask open-ended questions. So after you've asked an open-ended question, you need to listen. And the type of listening we're going to do is what we call active listening. And active listening means once a patient has stated what's happening, so for instance, you know, are you having pain that's keeping you up at night? The patient responds, yes, I'm having pain that keeps me up at night, and actually I can't sleep during the day. As an active listening technique, then you say, okay, so let me get this straight. You are having pain that's keeping you up at night, and you can't sleep during the day. Is that right? And the patient says yes. So active listening is really just parroting back what the patient said to you. But if you do that, that means the patient knows that you're actually listening, that you're paying attention. So that way it's confirming that you actually care and that you start to build up trust that way. That's a very, very important thing that you need to do. It's not just the dentist coming into the room and just giving out patient information the whole time, giving out education as to what's going to happen during the procedure. It's much more important to ask these questions and then respond to the questions in the proper way. That's what gets a patient moving forward with treatment, not necessarily talking about all the information that's associated with implants. So the way the restorative consultation is going to work is you will find patients through recall. So a patient comes in, you know, their partial gets put in the ultrasonic, the hygienist is seeing that patient. The hygienist says, oh, number 6 has caries and number 6 an abutment to the partial. And so then you'd have that conversation with the patient. You definitely not have a full consultation at that time. You need to have dedicated time for the patient. So you need to make sure that the patient is going to come for a free consultation. So I always say to the patient, you know, we've found that there's a problem. You have lots of different options. There's not enough time for us to talk about the options. So let's have you come in for a free consultation and we can go over all those options, including implants. And the patient will say yes. So we're going to dedicate 50 minutes for that appointment. That 50 minutes is not doctor time. You're going to take 10 minutes of doctor time, and the rest of the time is going to be your staff. So the way it works in my office is for 20 minutes, my financial coordinator meets the patient, takes them back for a cone beam CT, sits them down in the consultation room, and starts to build trust with the patient. So she starts to go over all of that stuff. We talked about the right open-ended questions. She goes about doing that. She does the active listening. She talks to them about that. And then after that period of time, she comes out and finds me. And she shows me the CT scan. And then we talk a little bit about what that patient has just said to her. and then I go into the room with her, and Ruth says, I've talked to Dr. Ferrier about your issues, and he's going to now talk to you, and then she leaves the room. So in that way, we have continuity, and the patient understands that we're a team and that everybody is working together and that we know what her concerns are. So during the 10 minutes, we're going to talk a little bit about how we go about that later, what the blueprint is for this consultation. But in 10 minutes time, you should be able to gain trust of the patient, and you should have that patient moving forward with treatment. Whether or not they have the money, because obviously the money is a big excuse, you're going to have them either doing financing or talking to your financial coordinator. There's no option for the patient to leave without doing one of those two things. So we're going to make a connection with the patient during that 10 minutes, and we need to find out the patient's true motivation. So once again, we reestablish what's actually going on and what the patient is really looking for. It's really crucial that we inform the patient of what they can expect, but we don't overwhelm them. So typically when I'm talking about doing full arch immediate load, I'll talk about either doing removable as an option or doing fixed. And that's as far as I get in terms of discussions with implant types. We can always do that later at a workup visit. For the consultation, you need to keep things very simple. And we want to explain to the patient why saving teeth at all costs is no longer as viable an option as implants, because the implants are more predictable. That's really important for a patient who's been in a restorative practice for a long time, because oftentimes those patients have done everything they can to save their teeth, and now you're telling them to take out their teeth, and that oftentimes will lead to a little bit of a disconnect, and some of the patients might leave the practice. The real key here is you always want to give an overall treatment fee. So that's going to be the restorative fee and the surgical fee. You don't quote your own fee. You quote a fee overall that's determined before seeing the patients for the consultation, specifically so that everybody knows exactly what that fee is going to be. So the restorative dentist and the surgical dentist know. So for instance, in my area, let's say my fee is $27,000. That represents both the fee for for myself as the restorative clinician, for my periodontist, and for my laboratory. So that's all things told. The other key that's extremely important is always looking the patient in the eye when you quote the fee. If you don't look the patient in the eye, that means you're not confident. That means the patient's not going to believe that you feel that the value of your treatment is worth the cost, and you're going to end up not getting as much case acceptance. The patient, looking in the patient's eye is extremely crucial. And I always tell people that who may come to our live surgery course, of all the things you can do, this is the most important one. So here's the blueprint of what we end up doing for our patients. The first key is rapport building. And oftentimes rapport just means we're trying to get in line and communicate well with the patient, so we're getting on the same page. I always end up talking about traffic. Sounds silly, but everybody has to deal with traffic. So when you talk to them, you say, oh, where are you from? You know, oh, how was the drive into the office? There was no traffic? Oh, that's fantastic. So you want to always say something like that, because everybody has to deal with traffic. So that's always a good start. You always say, how can I help you today? Or something along those lines. It doesn't have to be specifically these words, but you want to start out with a question where the patient opens up and starts to speak about what they're doing. Once they've said something to the effect of, my teeth are terrible, I really need to have them out, you know, I can't chew, then you say something like, can I ask you some personal questions about your situation that will help find the right fit for you? The reason we're going to ask personal questions is because that's what's going to start the patient down the path of trust. You know, trust is kind of like an onion that surrounds a patient, and every time you get a little bit further in, you take off a layer. And so asking personal questions and the patient saying yes is taking off the first layer of the onion. So once we're there, we're going to ask the open-ended questions again. So you're going to ask questions that specifically have the patient talk more about what's happening in their mouths. And then we're going to restate their issues while they're doing that. So that takes about 5 minutes to do the open-ended questions and restate their issues. You always want to take a look in the patient's mouth and talk about the CT scan. If you take a look in the patient's mouth, that means the patient understands that you actually care. If you don't look in the patient's mouth, they're going to be wondering why you're talking to them when you've never looked at their teeth. So when you do removable versus fixed, you want to show the patient the models. Implants can solve the problems that you have. That's what you want to make sure you state. And then you always want to have the patient say, you know, you want to ask the patient, how would implants change your life, so that they have to go in and talk about that. Inform the patient on what alternate treatment cycles would be and the cost of doing 12 implants individually. So you talk about what the cost of doing that overall would be, and then you quote your fee, which is going to be less. So for instance, if it's $5,000 per implant, just to do one arch, you'd be looking at $60,000. Your fee is going to be whatever, $25,000. In that way, you're starting high and you're framing things so that your fee is much less. And we're always going to talk about that fee as a value. And then you say something like, can you take on treatment at this time? If the patient says, yes, I can, and you have them talk to your financial coordinator. If you say, no, you can't, then you say, well, why don't we look into some financing options to see if we can get you qualified so that you can get the treatment that you need. So no matter which one they say, they're always going to talk to the financial coordinator at the end of the visit. Ruth is my financial coordinator, so I'll always start something like, great, let's have you talk to Ruth. So that's how you're going to run your consultation. And those are the steps that you want to take along the way. And this is what ClearChoice basically trained us on when I came on board. So what we're really looking at is transformations. Here's an example of a patient with an immediate denture that's not well fitting, and we give her something where she's more comfortable. She couldn't leave her house before, and now she's going to restaurants and she's feeling more social and able to be with her friends. Here's an example of a bartender. She saved up money for 25 years because she knew her teeth were bad. And then she gets a new set of teeth, and she actually changed her life and became a executive assistant. Example of a lady tremendously affluent, couldn't find the right dentist for 6 years. Eventually she found me and we were able to do treatment, and she was much more happy. So this is the type of patient that we see. A lot of times these patients may have money, or they may not have a lot of money, but they might have something saved up. And in those cases, you can access their emotions and get them to move forward with treatment. Here's an example of a patient, and this is probably my favorite patient. He was a patient when I was at ClearChoice, and he had multiple missing teeth, problems with his teeth. He came into the appointment 40 minutes late, and it had been a rough day for me. So I really just went into the consult room, told him this treatment's going to be, $60,000. It's going to be really expensive. It's probably going to be painful for the treatment. I don't know if you're going to want to do it. This is probably not the best approach for you. And he actually ended up writing a check right then and there for the treatment. I thought, wow, if that's what it takes to do the right consultation, maybe I should change up my style. But in the end, he gets treatment, and he can be somebody who, like you said, he was like that 10 years ago. So that's a big change in his life, and something that we want to do. So in conclusion, full arch immediate load is a very predictable option, and there are so many people who need to be treated. It's really going to be a huge deal for many years to come. Any surgical restorative team can treat patients like this with proper motivation and experienced support. And this is really a paradigm shift that we're seeing, and that's a really important thing for us to take into consideration, that this is just a part of the treatment spectrum, and that we all need to be able to deliver some of that care. So here's just a quick video of what we're doing at our live surgery course. Okay, so a couple of things we've seen, basically 50% growth over a 3-year period for our patients, our doctors who attend our Teeth Express course, and that's something that's been really, really just encouraging that we can actually see that type of growth within these private practices. Here is Dr. Sharafi, our partner, when we teach these courses. He's got a wealth of experience and knowledge. This is our laboratory partners who are involved in this. Once again, we encourage a surgical specialist, a restorative dentist, and a laboratory to be present for these types of trainings. And if you look at some of the other trainings, you know, a lot of the other companies are doing training for about twice as much as we do. They also have a very poor type of hands-on, and their surgical day is much less robust. So the idea is to be able to teach case acceptance and business training as well, and not just the clinical portion of things. So here we have our next 2 courses. We have February 1st and 2nd, 2019. This course has about 10 seats remaining, and we usually sell out of these courses. And then we have March 1st and 2nd in Rhode Island. So if you're interested, teethexpresscourses.com, that's where you can look and get more information about that. So I'm going to hand this back over to Dr. Sheldon here.
Dr. Ferry, this is a fabulous presentation. Let me give you some observations, and maybe you can comment on those. First of all, it's the realization that, in fact, these patients do exist, and they do exist. What's your experience in terms of the type of patient you see? And let me give you my observations and see whether it's the same for you and for others around the country. When we started going and marketing directly to patient, the one element that I was surprised at was the number of patients who had given up on dentistry and now were looking for an answer, and now we gave them the opportunity for an answer. So we saw patients who had been without dental care for 5, 10, 15 years, longer than that, and all of a sudden they came in and now they found a way of transforming themselves. As far as your experience goes, are you seeing the same thing, or are you seeing more of the patients who's just continued with dental care and finally they found that the dental care wasn't working and they had to go in the other direction, or maybe a little bit of each?
Yeah, I think, you know, with ClearChoice sort of leading the way with direct-to-patient marketing, when I was at ClearChoice, all we saw, you know, 95% of the patients were patients who were outside of the dental fold. So they hadn't seen a dentist in, you know, 20 years, 30 years. So that was the primary patient that we were seeing. And there's probably about 50% of the population that's living in that type of condition, you know, not seeing a dentist, kind of going down that road. And at a certain point, we'll hit a wall and have to go forward with the treatment like this. In private practice, there's probably 2 segments that I see the most. When I talk to restorative dentists, if a patient has been in the practice for a long time and has a partial denture, those types of patients are very prone to moving forward. And so that's a very under-tapped type of treatment group that I see a lot of. But then, like you said, I get a lot of secondary referrals of patients who haven't been to the dentist in a long time. That oftentimes is in conjunction with external marketing. So a lot of people who do more external marketing are going to see more of those patients who haven't been to the dentist in a long time.
Okay. The other, and I feel the same way. The other, I think the point that we see is when we get to the point, and understand I'm speaking as a periodontist, and so as a periodontist, we're used to saving teeth, or at least we were. When we get to the point of a sinus lift, seems to be the key element where we might transform from the sinus lift and replacing some of the posterior dentition to doing the full arch instead. Essentially, what we'll do is give case estimates on what it would cost for a sinus lift and restorations. And then the patient says, well, what kind of result will I get? And they'll still have the maybe ugly teeth in the front, but they'll have function in the back. And then they find out, oh, for just a little more, I can get a full arch restoration. Some of us, when we're particularly in the caries case, because a lot of periodontal disease patients can be treated. But in the caries case, if we start to get a little bit of deterioration, we've lost some posterior teeth, that might be the time where we say, all right, maybe there's another alternative. And frankly, we can price one alternative to restore the teeth. Here's how much it would cost for buildups and crowns and posterior support versus what it would cost in order to extract the teeth, put implants in, and have a full arch restoration that looks beautiful. That's what we're seeing as periodontists. Of course, there are a lot of periodontists on the line right now. And so there is that time when we have to make that transformation, where we can think, or at least give the patient the two different options, saying, all right, saving your teeth, you'll get this. Here's what our outcome might be. Here's the problems that may occur versus getting full arch implants and having the smile you've always wanted.
Yeah. I think the real key to this is that when you present multiple treatment options, it's very important to inform the patient completely, because when you go into a hybrid restoration, it's very different than if you do a full mouth reconstruction on teeth and then add posterior support. And most patients won't really understand that. They might just look at the price tag and say, okay, this is the cheaper version. And so it's really important to make sure that they understand what they're getting into. And so even though I'm a big advocate of doing full arch immediate load in a lot of different cases, I always want to make sure that I'm setting the right expectations. And that's one of the things that I would always want to make sure I'm doing before we go to that road. Because ideally, full arch immediate load is the last resort. I mean, that's what we have this treatment modality for. But sometimes you get these tricky cases where you're sort of on the fence and somebody could go either way. And in those cases, you just have to really inform a patient so that they can make the right decision.
Very good points. Just so you all know, Dr. Ferry and I met each other a couple of years ago at a BioHorizons conference, and BioHorizons has been very good at supporting continuing education for all of us, including our referring dentists or study clubs and those types of things. But then my associate had the opportunity of taking Dr. Ferry's course. My associate, Dr. Michelle Furtado, who does the surgery in our office now, and had a great experience with your course in Providence, Rhode Island. So thank you. Very good. Dr. Andrew Ferrier, thanks for a great presentation. We thank BioHorizons for supporting this. For those of you who might want some more information on the Institute for Dental Specialists, just write to lee@directorofdentistry.com, lee@directorofdentistry.com, and I'll give you some more information about what we can do for you as well. Dr. Ferrier, thanks again.
Great. Thanks, Lee. Take care.
Good night.